So I'm going to talk, I was asked to talk long-term prevention of cardiovascular risk in women with PCOS. Is there an evidence-based solution? And I hate to set a precedent for the world's shortest lecture. No, there's no evidence-based solution. I'm not sure there's even a problem. So thank you very much. I'm done. So let me go into why I think this is the case. And I think really, I think PCOS gets a worse rep than it actually is. And part of that is, we're all in a business to drum up money, whether it's from the government or the state or from drug companies, if I didn't even mention that. And so we have to present our disorder in the worst light as possible so that people think it's a public health priority. And as I've come to learn more about PCOS, I do believe it's a public health priority, but I think that we also have to set the boundaries for what the risks are and not raise undue fear in our patients. And in this age of the internet, most of my conversation and consultation is bringing patients down to earth that what they've read is not actually what they're at risk for. So I'm going to identify the risk factors for cardiovascular disease. I'm going to identify the data, the very limited data that women with PCOS have increased in early onset of events. And then I'm going to review treatment options to improve cardiovascular disease risk factors, because I certainly don't want you to leave here thinking that I've said that they have risk factors, but since they don't have events, you could ignore the risk factors. I don't think anybody would say that. I think we still have to recognize and ameliorate those risk factors when present. So first of all, PCOS. The one thing I can tell you about PCOS is that nobody knows what the clear definition for PCOS is. And I find it somewhat ironic that if you look at the ISI Web of Science, the most highly cited article in PCOS literature is the Rotterdam Consensus Conference, of which I was a part, which is just a bunch of experts that got together and kind of voted on what PCOS was. And if you look on the level of evidence, expert-based consensus is slightly below case reports. So there's no evidence to this at all yet. It's still the most highly cited article. What everyone does agree on is that this is a reproductive disorder that has metabolic implications. And the stigmata of PCOS are polycystic ovaries, PCO, hyperandrogenism, and oligoovulation, i.e. this presents as an ovarian disorder. So when we look at these various criteria, the NIH, which was the first consensus conference, the Rotterdam, the second one, and then the Androgen Excess, now Androgen Excess PCOS Society, I think they're all varying flavors of the same thing, but they do certainly increase the prevalence of PCOS. So for instance, the Rotterdam criteria, which allows you to have what we call the weak phenotypes of, for instance, polycystic ovary and androgen excess, increases the prevalence in the population by anywhere from 50 to 10%, so 50 to 100%. So if a prevalence according to the NIH criteria is about 5%, the Rotterdam criteria will be 10% in your population. The other thing that's important is, at least in terms of cardiovascular risk, is these diagnostic criteria identify women at varying risk. And so I think we have to be very clear when we look at our patients and we talk about risk, what exactly is the diagnosis of PCOS. So here's a study that summarizes pretty much what all the studies say, that if you take a look at the patients that have classic PCOS, which in this case, these are women that had polycystic ovaries, androgen excess, and irregular periods. These are patients that just had ovulatory PCOS, so they're having regular periods, but they have polycystic ovaries and androgen excess. These are patients with hyperandrogenemia alone. These are controls. And so you're going to see, as you have more stigmata of PCOS, you're going to see more cardiovascular risk factors. So these risk factors are manifold. So the classic ones and some of the newer ones, and I'm not going to go into every article because you can just open up your JCEM or your fertility and sterility or your human reproduction every month and find another new cardiovascular risk factor in women with PCOS, the risk factor of the month club. But I think these are the ones that I think we really should be focusing on, the classic ones. So does the patient have diabetes? Does the patient have obesity? Does the patient have dyslipidemia? Is the patient physically active? Does the patient smoke? So let's go into smoking. This is a study that we did for women seeking fertility. So you could argue that's probably, it's even more appalling that almost 20% of the women seeking fertility are smoking, given the known harmful effects of smoking both on conception but also on pregnancy loss and pregnancy complications. So even though these women were advised of the risks of smoking, still 1 out of 5 trying to get pregnant is smoking. And I don't have good prevalence data in a non-pregnancy seeking population, but it's my guess, especially since 22% stopped smoking to be in the study, it's my guess that 1 in 3, 4 out of 10 women with PCOS are smoking. We could end the lecture right here. Focus on getting them to stop smoking. That's going to do the most towards preventing cardiovascular events. If you look at what is the single most common metabolic abnormality in women with PCOS, it's dyslipidemia. And there's a meta-analysis that it's been EPUB'd by Fertility and Sterility. And what's interesting is that what's the factor that's most common? It's an elevated LDL, especially if you use the lower cutoff of 100 milligrams per deciliter. And there's varying factors that contribute to it that I'm not going to go into, but I do believe that certainly androgen excess in these women, i.e. testosterone elevations, contributes to elevations in LDL-C in these women. But that is your single most useful screening test. So roughly about 75% of women with PCOS, and this has been shown in other studies, are going to have a borderline or abnormal lipid level that is going to require some sort of counseling, some sort of intervention, some sort of follow-up. The other abnormality that's very common is glucose intolerance, and these are 4 studies now. This is in a U.S. population and a more obese population, as I'll show you. But overall, the rate of impaired glucose tolerance is somewhere in the range of 35 to 40%, and the rate of undiagnosed diabetes, because these are patients that were patients with type 2 diabetes were excluded from all of these studies, known type 2 diabetes. So rate of undiagnosed type 2 diabetes in the range of 5 to 10%. Now, you can argue that this is, and this data certainly supports it, this is primarily a disease of older and obese women with PCOS. But nonetheless, even women with normal BMIs have a 8 to 10% chance of having glucose intolerance, so much higher than you would find in a lean control population. And the other thing that I think is important is that this is primarily a glucose-challenged phenomena. So this is glucose intolerance. This is not fasting hyperglycemia. And I think one of the issues that I have, especially as I've done a couple of follow-up studies in which we've rephenotyped people over time, is the ontogeny of diabetes different in women with PCOS? So we think that in type 2 diabetes that as you develop glucose intolerance and then progressive beta cell dysfunction, eventually you're going to develop type 2 diabetes. So it's the strongest risk factor for fasting hyperglycemia is impaired glucose tolerance. But is there something in women with PCOS that might possibly prevent the progression from impaired glucose tolerance to frank fasting hyperglycemia? And again, if we were to just look at fasting glucose cutoff levels, we would miss the majority of women that have glucose intolerance. And that's part of the reason why most societies recommend screening with a 2-hour glucose challenge. And we have not quite come around like the ADA to recommend using hemoglobin A1C levels to screen for either diabetes or glucose intolerance. Most of these women from the studies have normal hemoglobin A1C levels. So metabolic syndrome is very common. This is based on the U.S. population, again, a more obese population than you're going to see in Asia. But 1/3 to 1/2 of women have metabolic syndrome. This is from a study, a multi-center study that was actually initially sponsored by Park Davis looking at triglyceridone. But I think it's representative of the U.S. population because there's close to 400 women in this study. And basically, the primary problem was the elevated waist circumference. And that was the single most common stigmata of the metabolic syndrome. Whereas elevated glucose, and again, patients with type 2 diabetes, i.e. a fasting glucose greater than 126 or greater than 125,